All right, good morning, good afternoon, wherever you are. Thank you all so much for joining us for today's webinar, looking at the Medicare Physician Fee Schedule for 2026, some of the proposed policies coming from the administration. We are excited to have two incredible experts joining us to speak on this today. Joining us, we have Michelle Hager, who is a partner with Blue Cirrus Consulting, who brings over 20 years of experience in health IT and is a recognized expert in telehealth strategy and implementation. And we also have Carol Yarbrough, who is a business operations manager for telehealth and virtual care resource center and manager, government billing and reimbursement, and clinical practice group with UCSF Health. She brings extensive experience in navigating complex federal and state regulations in all things telehealth and reimbursement. I will turn it over to you all. Thank you so much.
Thank you, Lydia. I'm going to share the slides and then pass it over to Carol. If there are any questions during the presentation, please feel free to ask them either in the chat or hopefully you can
I can see them.
see them.
Yeah.
And you can either ask him in the chat or at the end we can also open up for discussion. So Carol, I will pass the slides over to you and I'll drive along the way here.
Okay. Well, welcome everyone to the Michelle and Carol show. We're very pleased to have this opportunity, and thanks to CTEL for hosting us. Here's a quick disclaimer. The opinions expressed in this presentation are solely our own, not necessarily those of UCSF, CTEL. Since Michelle owns her own business, I'm guessing they're her own opinions and Blue Cirrus's opinions. They don't guarantee the accuracy or reliability of the information provided, CTEL or UCSF, but Michelle and I do. And we're just giving you what we know about what the feds are doing in this current moment of time. So next slide.
And it shouldn't be interpreted as an exhaustive list, just those things that we found to be the most important.
Yeah, or interesting or caught our attention. So here's our, which could be any shiny, pretty thing. So we've got learning goals. What is scheduled to happen with Medicare medical telehealth coverage? What is? Learn what's in store for telehealth and digital health. And of course, we're going to leave ample room for questions. We don't want to exhaust or bore you with our scintillating conversation, even though I find myself highly entertaining. Okay, next slide. Statutory factors. Okay, so I'm throwing up this invoicing slide first, just so you can get a sense of the impending, I don't know, the way the genie's being stuffed back in the bottle, as everyone liked to talk about that genie getting out of the bottle during the PHE. I just want to give you a flavor of what can happen, even though we've all been hearing about bipartisan support. So currently, up until September 30th, this is how we get to bill at facilities and non-facilities. If telehealth is anywhere other than a patient's home, or what can be considered a home, like their home away from home, anywhere that's not a facility, like a hospital, a SNF, an FQ, anything that I would say is licensed to be a healthcare clinic type of place. Anywhere where the government is acknowledging that there's a facility that can get facility reimbursement. Provider can be at home or at a facility clinic. Right now, it's known as their usual place of business, regardless of exactly where they're sitting at the moment in time. If that patient is at a facility, you get a facility pro fee rate. And for Medicare, this means that you're getting I don't know, what is it? 40%,
30. Yeah.
30% less than what a global fee would be, which is what you get at the non-facility rate at place of service 10, a patient's home. So for behavioral health plus medical management, so you get to do a 908 code plus a 99214, or medication management, patients at home, usual place of wherever the provider is going to sit. You get the non-facility rate, which is place of service 10, and it's that plus 30%. And the reason they're doing this is that when a patient comes into a clinic, there's also a facility fee that's reimbursed by the government, whether it's Medicare or Medicaid. So why would a provider get the full non-facility rate? But that's what we're getting right now, because they're not paying us the facility rate. I don't know. It makes sense to me. Medicine visit, which is anything that's medical, non-behavioral health, usual place of business, you get the non-facility rate. So I'm at UCSF. Our behavioral health providers and our medical services providers are seeing patients in their home within the confines of the city and county of San Francisco. We are getting paid a non-facility rate for services. Fantastic. Okay, next slide. Not so fantastic if it after September 30th, with all the caveats about originating site, metropolitan statistical area, physician shortage area, HRSA designated, blah, blah, blah. This is what's going to happen afterwards. So for facilities such as UCSF, if the patient is not in their home and they're at an eligible originating site and geolocation, which would be, I don't know, Mendocino, because it's a physician shortage area, and there's FQHC there. So it's the provider location is at a facility clinic, and I put to be determined because this is just about physician location. And at UCSF, I think our providers are all coming back to work. Not sure. It's a tight squeeze, but reimbursement is the facility pro fee rate, the 30% less. Thank you, Michelle, for now. That's going to be emblazoned in my mind and yours forever, everyone on this webinar. So if the patient is at an off-campus outpatient hospital, HOPD, no, wait, place of service 19 or 22. Oh, patients at home, not an eligible originating site, and we're providing, the patient would usually be billed at place of service 19 or 22, but they're at home. The provider is either at home or at the facility. We're not going to get reimbursed in San Francisco for patients located within the city and county. I don't know what leadership's going to do here, but I don't know what they're going to do at your academic medical facilities or medical centers. But what we had done in the past was append the GY modifier, because after September 30th at midnight, telehealth in a patient's home within a city will no longer be statutorily acceptable. It will be excluded. Place of service 10 for behavioral health, though, we're still going to get the non-facility rate. For a medical visit, no soup for you. No, nothing. CPT plus GY modifier. So this is the impact of what the geolocation and eligible site means for medical services if an extension is not granted by Congress. And these are regulatory issues as opposed to administrative. Next slide.
So Carol, I'm just going to ask a question that might be on others' minds on this one. So just to clarify, if the patient is currently in an urban area or not defined as a geographical rurally defined geographical site restriction, then they will not get the facility pro fee rate. They will not get any rate at all, or just not the facility addition.
We won't get anything at all.
Right.
So it's not reimbursed. Like the third row there, that's for behavioral health. So you
Yeah.
get a non-facility rate, even though you're at, because behavioral health has been included within the Social Security Act, Section 1840M, I think it is, as an acceptable place of service.
So almost the geographical site restriction reverse that we've had in the past.
Yep.
Rather than it being excluded in the rural areas, now we're excluded in the urban areas.
Right. Everywhere.
Yeah. Okay.
Yeah. And I know our PTs are not going to be happy at UCSF. This is part of the continuation that was enacted in March of 2025. OTs, PTs, SLPs, and audiologists were extended. These are not on the eligible provider telehealth list in the Social Security Act. They will no longer be able to provide Medicare beneficiaries with reimbursed telehealth services.
So 2 places to currently comment, because they did not include these provider types, these eligible providers are qualified health professionals in the new PFS. They need to make sure they add them back in, because that may have been an oversight. We're not sure, but that's an opportunity to comment in both of these places.
True, because if they do include them in any bill that might be pending, then we do need them to acknowledge, even though their services are still on the Medicare telehealth services CPT code list, they do need to acknowledge that this will be reimbursable on the CMS 1500. I need to check OPPS to see if they need to do a carve out for that as well. So that might be another opportunity to say, look, if this bill is passed, be sure to add these people back in as eligible providers within the fee schedule. Good point. I didn't even think of that.
Yeah.
Great. Yeah, next slide.
And thanks, Lydia, for putting the PFS in the chat.
Oh, yeah. So, okay, so I just thought it'd be interesting, like, how many working days does Congress have in September? So the House has to pass anything first, right? They have 12 working days. This is a calendar I found online, like Congress workingdays.gov or something like that. You can Google something, it'll bring up a site. And everyone's on vacation this month. I haven't heard of any backroom deals about telehealth. I mean, I'm not trying to be negative. I'm trying to be, what is it? Hope for the best, but expect the worst. Then anything that's passed for the continuing budget, because guess what? The budget dies as well as September 30th. Like the federal government might shut down. So the Senate then, once they get any kind of funding bill that may or may not include telehealth re-inclusions, I don't know, 4 days, 5, to kind of hash through the Senate version of the bill and then get it signed. So I'm trying to be positive. I mean,
Sure.
they managed to kill the 2-year extension within a day in December of last year. The not yet current administration. And so maybe they can put it back on for 2 years within a day.
Certainly possible.
Yeah. Yeah.
I think the message is there's not a lot of time, so don't rest on your laurels to comment or to reach out to your legislator.
Yeah, and you've got through September 12th to comment. And if anyone has any questions about how to do that or how to sign on to the CTEL comment letter, contact Lydia, contact me, Krista, Michelle, and just say like, oh yeah, this is a bad thing. And in that thought too, like start thinking about what your backup plan is, like what other kind of virtual health services you can provide that are not necessarily synchronous audiovisual and are audio only.
Right. And I would also say if you happen to be a member of HIMSS or other professional organization, you can still comment under those organizations as well who are also advocating on behalf.
Right, like the CHI as well.
Yeah.
They're
Yeah.
submitting it quite lengthy. All right, so administrative factors. I'm going to pass this over to Michelle.
Okay, so there are a few things that, thank you, Carol. So there are a few things that will change for 2026. So Carol was kind of talking through those things that extend through September 30th and a few PFS as well. But we're talking about the new proposed rule.
Calendar year.
Yeah, so starting at the beginning of 2026, in the proposed rule, we do have the deleted code for G0136, but we will, and that will be deleted if this is finalized. We do have, I think, over 100 that are defined as permanent, so there is some good news in there. A lot of them that would be permanent. And then these that are additions that are at the bottom under table 9, those are additional services. So multifamily group physical psychotherapy, that is a great add there, as well as the group behavioral counseling for obesity, as well as you can see infectious disease and auditory sound processing. We don't have the actual category number for the 92623, but that also is under the auditory sound as well category. But interesting there, usually done by audiologists or other therapists that have now not been included on the list. So, we're starting to see some inconsistencies essentially there. Anything that you would add to that, Carol?
No, I mean an ENT, I suppose, could do that kind of technical work and bill for it themselves.
Yeah. Yeah. So good news, some good news for 2026 and some of the codes that'll be available. In addition, we are seeing, as we said, the addition of the group therapy and the obesity counseling, and we said the ENT and audiology codes. Even though the E&M code was not adopted, we can use the standard E&M with the modifier for telehealth. So for the group therapy, just wanted to give some practical examples around that. What does that look like? So if you have a family group therapy via telehealth, that was previously not covered. So now you are able to have, a family therapy session and group therapy be paid for via telehealth, which could be really helpful. We know this comes up a lot with folks that are doing behavioral health services, particularly on the family side, where maybe mom and dad are divorced and they're in different or just traveling, so they're in different locations.
Yeah, and it did say multifamily too, so it would also apply to
Correct.
numerous families, all kind of discussing, how to deal with your dementia patients, perhaps, and like the sadness the group is feeling around it. And don't forget to bill group therapy via telehealth for Medicare, or even for just in person. You have to have an E&M visit billed for each encounter aside from the group visit. It's very strange. So be sure you look into that and the rules around billing group visits.
Yeah, so one of those, they have to have an E&M, but then you can do your group thing, which is probably typical to clinical practice.
Yep.
So for FQHCs, any of the non-behavioral health services are extended through the end of 2026 for FQHCs and rural health clinics, which is great. And then the same with the G2025 is on fee schedule as well. And then for again, we wanted to put in the practical example here. So you could, as an FQHC, continue to keep your audio only visits for hypertension patients and bill the G2025. So a
With a
copy.
caveat, as long as you are in a geographic a geolocation that's acceptable, and on that HRSA address list, you can type in and figure out if your FQHC is an acceptable originating site.
Right. If it's in an urban area, again, what we said initially would apply. No urban area, only rural. So rural health clinics would be in the clear for sure in this space.
Yeah.
Thanks for that clarification. A couple of other things. This is again with the caveats, as you said, originating site and geolocation. So you can see the repetitive nature of this. Please comment on that because that is almost that reverse geographic site restriction. But we do have permanent change to the Medicare list. So there's no frequency limits, which is great. So any subsequent inpatient visits, subsequent nursing home facility visits, and then the critical care consultation. So in the examples, again, practical examples for folks to know, any kind of person that's working in a SNF can check on one of their patients, a CHF patient, for example, daily via telehealth, which is a great addition for those patients that are in long-term care or skilled nursing facilities. For critical care, anybody that's doing a tele-ICU program, any daily rounding and ICU e-consults are, if they're medically necessary, again, no frequency limits there as well. Anything you would add to that?
Yeah, and I just want to point out that this does not include 99291 and 99292. I'm just kind of wondering if those are going to come off the list. It didn't say whether or not they were going to be deleted or not, but it says they specifically said these critical care consultations, the G0 codes, didn't specify the 99s. So that might be a comment to ask for clarification. Did you mean to include? Which would be great, because then you can bill for 30 minutes instead of a full hour.
Good point. Yeah, it could have just been an oversight. We talked about this, no frequency limits review. Those frequency limits have been removed. This is what happens when two people do different slides and they merge them together. So sorry, we didn't get rid of that one. And then I'm going to pass this back to you, Carol.
Okay. So there's a new revised way to get codes on the telehealth services list. It always seemed kind of confusing to me, like what? Yeah, okay. So I don't know. I don't even know what those 2 extra steps were there for. Like they were kind of repeats of the first 3. So step 1, determine whether or not it's payable under the PFS. So you go down to where you go onto the CMS website where you can download the worksheets for the physician fee schedule, even the proposed. And it's addendum B, which holds all the CPT codes with the work RVU, practice expense, Medicare expense, and then the total RVUs. You're going to see if that's on there and it's separate and it's payable, it'll indicate whether or not it's payable on the PFS, just on that spreadsheet. You've accomplished step 1. You're like, there it is. I'm going to be able to ask that it be added. So step 2, is it subject to the provisions of section 1834M? Is it in an originating site that's acceptable? Is it in a great geolocation? If that's going to be the case after September 30th. Step 3, and then review the elements. And can it be done? Is it medically possible to do this service via interactive telecommunication system? And I like how they changed that to interactive telecommunication, because that does include audio only. That's a nice thing. Oh, I praised the language for the first time today during our webinar. See, I can be positive about the PFS. And now they're just saying there's no provisional versus permanent. It's just permanent. But you see, they're just going to delete stuff off if they don't like it anyway, like the social determinant of health code. They're just deleting that altogether. I think
Right.
our facility just finally implemented, like, similar to depression screening. This was an SDOH screening. It's going to, kind of really get down in the record whether or not someone was unhoused or had difficulty with transportation via a questionnaire that would be paid for, and it kind of pays for the administrative costs of the clinical staff or the provider assessing these things via a questionnaire. It's a nice thing. Well, they're saying that's part of the MDM of the E&M service. So be sure, if you're still administrating a SDOH assessment, which you can also find formally on a CMS website. I haven't looked recently, but there are standardized questionnaires that you can actually integrate into your medical decision making and state something like via the SDOH questionnaire, which took me an additional 5 to 10 minutes to assess. And that's why this entire E&M encounter took me 55 minutes. And then, you can still kind of budget for that lack of reimbursement, of which it only paid $15-16 anyway. But it doesn't give it like that validity, that operational punch that it did before. Anyway, I digress. So it's not saying provisional anymore. If it makes it to the list, it's on it. If it passes through these these 3 steps. And then the deadline to email them and say, hey, I've determined step 1, 2, and 3. Please consider adding this CPT code. Unfortunately, people were saying, hey, put the AMA's telehealth codes on there. Well, it wasn't separately payable under the PFS, so that was automatically negated. And they did use that example in the proposed PFS for this year. So don't waste their time. Look it up.
Yeah, unfortunately, but it does make sense to, take the time to do it, especially if it's a code that you're using today, like you talked about the SDOH. That doesn't apply to the health risk assessments, though. That's still
Right.
that's still in place.
PHQ-9 and all that stuff. That's fine. Yeah.
Yeah.
All right, next slide.
Yep.
All right, virtual direct supervision. This is pretty cool. So there are three different kinds of supervision. There's general, which means your staff can do anything at any time as long as they're acting under your plan of care. So general supervision captures activities for chronic care management, principal care management, transition care management. Direct supervision means your provider is in the building. So if anything goes wrong, clarification is needed. The direct supervision is not the third kind, which is personal supervision, meaning the provider must be in the room. Case in point, personal supervision during a minor procedure, which is doing stitching up of a small cut. Provider must be there the entire time. Major supervision for a major surgery would be, being there at the time the crucial portion of that surgery is undertaken. So that's personal. So direct means you got to be around, but not in the room. They are permanently allowing virtual supervision. And this is not subject to geolocation. This is not subject, well, it is subject to originating site because usually the patient's going to be in the office, right? There are some instructions, incident 2. So I'm seriously, I think we need clarification about facility-based services. It does state employed by the physician and working on direct supervision. So this seems to apply only to non-facility personnel. But how about personnel which are employed by the practice indirectly when they work for the facility, and that medical group is paying, taxes to the facility for the RNs to be working under their general supervision.
I see what you're
Yeah,
saying. Yeah, like a
it's
third
bizarre.
party company.
Yeah, yeah. So, our facility folks are employed by the hospital, and there's a medical group that, the physicians are not employed by the hospital. They're under contract with the hospital. So, there must be a way. So that should be clarified. Somebody asked that. Okay. And then 99211, office and other outpatient visit, usually done by an RN. Or and may not require presence of physician or other qualified QHP, which is a nurse practitioner or a physician assistant, someone who can write an order.
Yeah, anybody that could write. So it could be an ARNP that's writing one for an MA, or,
Right.
any of those. And I always term or explain direct supervision as you have to be breathing the same air, essentially, that's coming through the air conditioning unit, right? So you have to be breathing the same air. General supervision don't have to be breathing the same air. So the fact that we can do this via telehealth is a huge, because you're not going to be necessarily breathing the same air. You're going to be in two separate places in this case, now being
And
allowed.
only when you're needed. So you don't even have to like be on a video at like max headroom the entire time looking around. Only when you're needed.
Yeah, good example. So for my state in South Carolina, physicians and PAs that are or physicians that are supervising other people, they have to be within 100 miles of the clinician. Well, a lot of times the islands are far away from each other, and they're not actually able to meet that distance site or that distance mileage. And so now you're able to have some supervision if needed via telehealth, which is great.
So
Go
yeah.
ahead.
Yeah, no, it's just going to be great for our cardiac rehab people.
Yep.
You don't have to have an NP in the next room while your tech is there overseeing exercise on a treadmill for cardiac rehab, not intensive cardiac rehab, just cardiac rehab. Same thing for pulmonary. Well, it is ICR. I can't even read my own slide correctly. Anyway, why don't you cover the first half of this slide, Michelle?
So exclusive of audio only, the extensions described, except for those that are under the global. So for global surgery, this is where it can get a little bit sticky, because there are some people that are trying to do some of the programs. I mean, this one example here is endoscopy, but there are some people trying to do surgical optimization as well. We're trying to do some surgical optimizations. If they are within the global surgery, then they will be excluding that, but there are some audio only as well that you can use under direct supervision again. So here's your physician on virtual visit. There's your NP or ARNP or RN doing something in a completely different location, which a physician could theoretically be directly supervising multiple people in multiple different areas, depending on the type of business that you might have.
Yeah, and I was going to say that the indicator of 10 global surgery days or 90, 10 indicates a minor procedure, usually 90 indicates, heart transplant, I guess. And all that means is that they're trying to differentiate between minor and major surgery. And where you can find these indicators is on that same addendum B. It's like a magical little spreadsheet that shows you everything you need to know about CPT coding. You're not going to find this in the AMA CPT code book. It's going to be indicated on that spreadsheet.
And there are a couple of resources links that we have in the slide deck as well. They're at the end. So it could be helpful. Okay, so same thing here under audio only rules. They are going to be allowed still for behavioral health services. Again, assuming that is allowable by the scope of practice for that state. And I only clarified that on there because there are some states where LCSWs or other types of behavioral health providers might not actually be able to do telehealth. It might be called out specifically, so only made the caveat there. Excuse me. And then the virtual direct supervision only requires the audio visual only. So that again is, the same thing where we're on a video call like this, we're on a Zoom call. So you can see here, psych follow-up can be a phone only. And then the incident to supervision has to be video though. So if we're doing, supervision and the person is doing, as Carol said, incident to supervision, that has to be via video, but most of them are phone only, audio only. So the majority of them, you can do that and it's allowable now, which is great, assuming it passes. So we don't have to comment on this one less to comment on.
We like this one.
Yeah.
Gold star.
Yeah, exactly. This is just a clarification again for the virtual direct supervision, permanently allowed by a real-time audio video. So again, the example that we use, an NP does those chronic care visits while the MD is supervising via secure video. So you can be potentially, depending on your your type of business, you could be in one state and assuming you have all the proper licensure and all of that, and then you can supervise multiple NPs via direct supervision. So again, we like this one too. Where we don't like it
We
is
don't like this.
we don't like this one. Not great for the residents, not great for, where we have teaching hospitals and there's still time to comment. You can see that in red. That is not going to be allowable in an urban area. So if you are a teaching physician in a really, it doesn't matter, but if you were defined, I was going to say really big city, but it doesn't matter if you're a really big city, as long as you're defined as an urban area, you will not be able to do physician supervision within your teaching capacity via telehealth. It will have to be in person. If you are doing it rural, then yes, so we almost have the reverse discrimination that we saw before. Again, same thing. If you're doing and teaching physicians you're teaching students in rural areas, then yes, you can do the supervision. That is allowable. And you are, able to be reimbursed for that. But unfortunately, right now, we need to comment on this because I have several clients and over the years have had other clients where we were in Boston or we were in LA, and to go from one part of the city to another is multiple facilities within that city and traveling between those facilities to try to supervise. And we all know we already have a physician shortage and we have a supervisory physician shortage for any of these residents, et cetera. This is a really big restriction where we have most of our academic medical centers in urban areas. I don't know how many of them are in rural areas, but you'll be able to continue, but there aren't that many, if any. So please.
And I love how it says they also say in the rule, you can do it for free if you want. Oh,
yeah.
Oh, you can still teach telehealth for free.
Yeah. Nobody wants to do that, of course.
Yeah.
So comment on that one, please. And on the originating site fee, there is a rise for the fee schedule up to about $31.85. And you are able to, in a critical access hospital, for example, you will be able to get around $31.85 per a hosted teleneuro consult. So there are some critical access hospitals that are providing some telehealth services to other areas in their region, doing that to rural clinics or to an FQHC or other clinics in the area. And if that's the case, you will be able to get an additional fee, a rise in that fee for the originating site fee.
Just going to point out, it started at $20 in the year 2000. So 25 years later, it went up $11.
I don't feel like that doesn't
Yeah.
give the positive spin. It went from
It
$20
gets a
to
half a
30,
star. I give it half a star.
half a star for that one.
Yeah.
We like this one.
We do.
Those that are coverage expanded, obviously for remote monitoring, especially in the digital mental health space, because we know remote monitoring is not considered quote unquote telehealth, which is great. So they have separate billing rules. We now have the new less than 16-day requirement for RPM and RTM that are proposed. So if you are going to comment that you like this one, because we want this one to continue and we want this one to go forward, that we don't want them to rethink the under 16-day proposal. So obviously with an example here that if you are doing, pediatric psychiatric services for ADHD or other types of behavioral health, and you have prescribed, an ADHD digital therapeutic, then you are able to monitor them and not necessarily have to get 16 days of data, which is great.
It's kind of counterintuitive. I mean, somebody with ADHD is going to do 16 out of 30 days. Like, just do 2 and you can bill for it. It pays about 50%.
Yeah. And the smart people that like Carol that I've talked to, this 16 days or under 16 days, it doesn't necessarily have to be in a calendar month. It's just a 30-day period. So keep that in mind when you're billing. You may have been thinking, oh, I'm not going to get 16 days in August because I saw them on the 25th of August or whatever. That doesn't matter. It's just 30-day period, not a calendar month.
Could be a challenge to bill, but billing's challenging anyway.
Yeah, at least the first month. Yeah, right. Exactly.
Yeah.
Exactly. So again, there are a couple of upticks on telehealth reimbursement for behavioral health. They get some modest upticks here with the conversion factors, and we like that as well. So it's from an outlook perspective, from a behavioral health perspective, that is a good thing. They are getting some increased reimbursement and not getting cut, which we are seeing in other areas. Anything to add to that?
Yeah. So the APM versus non-APM, like an APM is an ACO. So it gets more money than fee for service. It's like 40 cents difference, but it adds up, right? So if you're not in providing services within an ACO or other approved payment methodology, or your fee for service reimbursement. So they have 2 fee schedules. This is the first time ever, and this is all based on movement towards quality-based reimbursement.
Yeah.
It finally happened.
Yeah, and I think we'll see more and more. I mean, we might be, in furious agreement, but I think we'll see more and more of that given the changes that we see at CMS. Just a note, we're almost close to the end of our slides. If you have specific questions, put those in the chat. So this one's all in red to comment. I'm going to do a quick one and then you can add to it, Carol, because this is such a difficult one. Currently, any of the distance-based providers use their home location instead of their practice location when you enroll in Medicare telehealth services, right? So you are enrolling your home and you are billing from where you are located. If you are located in Kansas, you're billing from Kansas, not where the patient is. And I know we've said this many, many times.
And your practice location goes on the invoice.
Right, exactly, on the claim itself. So this is the impact. So without an extension to that existing proposal, so existing service, that will end on January 1st. So in box 32, where we've been fighting over and over, for a long time to make sure that the physician's address was not exposed and wasn't out there on an EOB somewhere, that would now be displayed, and it would be included in box 32. So we don't want that. We don't want we think this is probably an oversight because this is not what anyone wants. It's been
Yeah.
what we've been communicating, but something to consider. This is a tough one. And again, I think Carol mentioned this earlier. Just think about, what is your plan B? Because if you do have a patient, you may want to look at some of your patient communications that gets a bill that says, oh, my physician is located in Kansas and they're getting services in California, or vice versa. Then they might say, well, I didn't get any services in Kansas, or I didn't get any services in California, or whatever they're looking. What's going to be the communication to the patient for any confusion that may be incurred by them, that you may get a call about after January 6th, after January 1st, if this is not continued. So comment. This has 3 red comments on it, so please comment on this one. Anything to add?
Ditto. Just ditto.
Yeah, ditto on that one for sure. We talked about how we have all these resources. Carol is always wonderful to include all of these. So Carol, you just did a phenomenal job putting all these links together. We will obviously provide the slides to anyone through the CTEL mechanisms of doing that. But these are great fact sheets for all of us that provide this type of information, and you provide this to your compliance departments. We want to be able to show you the links of where we got this information for a couple of different reasons, obviously, so that you can prove to them that we're not liars. And then also, if by chance you do get audited based on the work that you do, you can specifically point to that and say, this is why I did it. This is why I didn't just make that up out of the air. I looked at something and I interpreted it this way.
Any questions?
Any questions?
Everyone knows everything they need to know. Got to thank you.
Yeah. So there's some good and there's some bad, right? There's some medicine and there's some syrup, but not ideal. Are addiction treatment services considered behavioral health services or medical? I think
They're behavioral health,
yeah.
because the home and originating site includes SUD. And that was even before the PHE. SUD had a separate pay schedule. Sure. Not a different pay schedule. It pays bank. Like a home SUD service is like $400.
Yeah, I agree. I think any of those behavioral health services, and then you can see they're just continuing to pile it on. So if you're doing behavioral health services, I think you can pretty much consider yourself in the clear. Yep.
Yeah.
Definitely Jody on the mental health services. Yep.
The only thing that might not be extended as well is, okay, you're grandfathered in because you've had a behavioral health service during the pandemic. So you're an established patient. And that means whenever the extension, now is it through the 31st of this year or is it September 30th? I think it's September
30.
30th.
Okay.
Right? Is
We can
it?
clarify.
Yeah. So the behavioral health requirement that you see the patient in person.
Oh, that's the 30th of September. Yes.
Yeah. So it's codified in the Social Security Act. So that's why it's September 30th. If you see all of your patients like in September, that means that you grant them a whole extra year to not have to come in and see anyone in person. And that means you specifically, not anyone in your practice.
Yeah.
And if you saw them in March, and this expires, then they have to come in person in March of 2026.
Assuming it doesn't get codified in September at some point.
Exactly. Exactly. Yeah. So thanks for your attention. And
Any other specific questions for folks? Lydia, you are becoming a coding guru as well. Anything that you wanted to add to this that you have seen and that comes to mind for you?
Yeah, I did want to highlight a couple RFIs that were included in the fee schedule, more opportunities for folks to comment on. One of which is an RFI regarding the practice expense valuation for artificial intelligence and software as a service input costs. Currently, these have been considered as indirect practice expense inputs. However, CTEL and other organizations have encouraged CMS to move these to direct practice expense inputs. And so CMS has issued a pretty lengthy RFI looking for more specific information on how they can better incorporate these costs into their practice expense methodology. Another one that I also wanted to highlight is regarding the um, valuation
Yeah.
between remote patient monitoring and remote therapeutic monitoring. They are asking whether or not these should be valued similarly or if they should be valued separately and differently. And so they're looking for information about things like the varying levels of intensity between the two services, and with a specific desire for data and clinical evidence. And there's also a pretty broad RFI on digital tools for encouraging healthy lifestyle, which is a pretty big priority for the administration and the leadership at HHS as well, kind of playing into their big theme of focusing on chronic disease, and specifically what digital tools could play a role in that specifically. And so in addition to all the policies covered, these are also some opportunities to provide information, evidence, research, to help CMS shape its future policy as well.
Yeah, I love those three. Lydia, thank you for bringing those up. And then on the RTM and RPM one, I'm just gonna put my own personal plug on there. Maybe Carol may have one on her own, but to comment on that, because looking at it more and more, they are really trying to understand if there's a cost differentiator, right, between our remote patient monitor or remote physiological monitoring versus a remote therapeutic monitoring. So if you're currently doing a remote physiological monitoring and you have technology that you're paying for, that you're distributing to the patient, or third parties that are monitoring this, and what is required, all of the pieces that are required, there is potentially a much higher intensity between these two services. And I don't want to devalue one versus the other, but keep that in mind to definitely, if you're doing these programs, to comment. They do seem to be very interested in this. Anyone that's special to you, Carol?
I have to agree because software as medical device, there's just so much R&D that goes into that, and specific to, oh, can we all comment on cognitive behavioral therapy and actually ask them to value it and not leave it to the max? I would love that too. I would love that. CBT is important. So,
Yeah,
yeah.
absolutely.
I mean, the max, like they're like, oh yeah, submit a comparable service to us and we'll consider paying it that same fee. And all you're doing is sending in an MSK claim or an MSK valuation. And it's not the same thing.
No, exactly. And
Yeah.
I'm actually going to put our email addresses in the chat because I don't think we were smart enough and put them in the slide deck. So they are coming in the chat if anybody.
You're so kind. I always usually purposely leave mine out. Just
Oh, sorry.
I'm
Now
just
you can bug, now you can bug Carol directly.
Yay!
But yeah, thank you so much, everyone. If any questions, we always talk about this during the remote group, the reimbursement work group that Carol does such a great job managing. But if you have specific issues that you are dealing with, that you're getting denials on or challenges, we would love to hear about those because that helps drive the meetings on the work groups. Otherwise, we're just kind of trying to figure out what we think is important. So we'd rather know what you think is important and talk through that as well.
Yeah. Yeah. Well,
Thanks, Jordana.
under the wire. Thank you everyone for sticking it out with us. And of course, Lydia for being a great
Thanks for
host.
having us, Cito.
Yes, thank you. Take
And
care.
thank you. Hope you all have a great rest of your day.
Thank you.
Thank you, Lydia.